Okay, that's possibly working. We'll see. I'm not very good at seeing. Oh yeah, okay. All right, so let me start by introducing Josh. Josh Seim is an assistant professor of sociology at the University of Southern California. Prior to joining the department in 2018, Josh earned a PhD in sociology from the University of California, Berkeley. He conducts research in the governance of poverty and suffering with substantive expertise in the sociology of medicine, punishment, and urban sociology, among other things. And Josh is also a fantastic colleague and an accomplished teacher. So today we are virtually launching and celebrating Josh's first book, Bandage, Sort, and Hustle, published by the University of California Press. Josh set out to answer a not so simple question: what is the role of the ambulance in the American city? And to answer this question, he rode along in ambulances in a large California county for a year, and then found himself working as an EMT while simultaneously conducting fieldwork for another 9 months. These ethnographic observations and data from medical records and other sources inform the analyses in this book. So Josh approaches the ambulance through the lens of a labor process to illuminate how does our society manage urban suffering. Josh loves an analytic diagram, so I replicated this one from the introduction of his book to provide, I think, a really brief overview. So Josh situates the work of the ambulance relationally to understand the constraints and opportunities that shape it as an institution to manage the poor. So in part one of the book, he focuses on the work of the ambulance crew, how bodies are bandaged in the face of extreme suffering. In part two, he focuses on these horizontal relationships between ambulance crews, police, and nurses to understand how bodies are sorted across institutions. And then in part three, he focuses on the vertical relations and hierarchy that the ambulance is embedded in, showing how bodies are hustled in response to the pressures of bureaucracy and capitalism. Finally, Josh provides some theoretical and practical conclusions about what the ambulance can teach us about patients, workers, and inequality. People interested in medicine, poverty, inequality, cities, and frontline workers, topics of renewed importance these days, will certainly find new insights in this book. So today we have three brilliant panelists who will each provide about 10 minutes of comments. Neil Gong is a sociologist at the University of Michigan Society of Fellows and an assistant professor of sociology at UC San Diego. His research interests include social control, sociology of medicine, law and society, urban sociology, ethnography, and violence. Our second panelist will be David Brady. Dave is a professor of public policy and sociology at UC Riverside and director of the Blum Initiative on Global and Regional Poverty. His research interests broadly center on poverty, inequality, politics, and public policy. And our third panelist will be Tania Jenkins. Tania is an assistant professor of sociology at the University of North Carolina. Her research interests include medical sociology, work and labor markets, stratification, gender, and ethnography. So our panelists are each going to take about 10 minutes to provide their remarks. After that, Josh will respond for about 15 minutes to some of the issues raised. And then in our final 30 or 40 minutes together, we'll have a Q&A. So we're going to use the chat function for that, which you should see at the bottom of your screen or device. So when we get closer to that time period, you can start thinking about your questions and pop those into the Q&A. I will recognize you and unmute you so that you can speak directly to Josh, and we'll get to as many questions as time permits. So with that all said, we're going to get started, and I will turn the floor over to our first panelist, Neil Gong.
All right, thanks so much to Josh and Anne for inviting me. This is a really amazing panel to discuss an important book that I've personally learned quite a bit from. It's also great to see so many familiar faces in the audience. So my name is Neil Gong, and I'm a sociologist who looks primarily at community psychiatric care is my main project, and my in-progress book compares public safety net services for poor people with elite care for the rich. And that research has brought me in contact with some of the issues Josh illuminates in Bandage, Sort, and Hustle. And Josh offers what he calls a labor-centric approach to poverty governance. It's helped me see that much of what I observed in treatment and management of psychiatric disabilities is wrapped up in labor questions. That is to say, delivery of the actual services may be determined by work conditions and options available to people on the ground as workers. So people governing and managing urban poverty, whether cops, medical workers, mental health workers, must be understood first and foremost as workers who are engaged in a labor process. We have to consider things like controlling one's time on a shift, trying to get off of a shift. Questions about what people see as real work versus they would call bullshit work, and struggles with others, whether that's other professionals or with bosses. And what we better understand about these governance processes performed on poor people is that they're shaped, is what we can see, better understand what we can see is shaped by these horizontal relationships with these other workers and agencies, and these vertical relationships Josh talks about, often with management and with the demands of capitalist profit making. So the example I find most useful to get into this is watching different kinds of workers, in Josh's terms, burden shuffle problem people. So perhaps this is police and ambulance workers who want to avoid the homeless person, the person with a psychiatric disability, the intoxicated person who passes out on the street. And these workers might see the person as an annoyance and as a burden, and they're not really equipped to truly help or deal with it. So what they do is they try to shuffle this burden off to other people. So there may be a struggle over who has to deal with this. So to the police, it doesn't feel like real police work. To the ambulance workers, it doesn't feel like real healthcare work, and it's a quote unquote bullshit call. And so these kinds of horizontal struggles here. And so maybe the cop wants to turn it into an emergency psychiatric hold, whereas the ambulance is trying to get away from it. And these actions here that, again, are shaped by these people trying to, say, get out of certain tasks can have substantial impacts on people's lives. So Josh gives these examples like, an ambulance crew doesn't want to take someone to the psychiatric facility because it's super inconvenient. It's far away, there's a long triage time. It's the end of the shift, people want to go home. So instead, maybe they start fishing for medical concerns. Do you have chest pain or nausea? So if they find these things, maybe you can take the person to a medical ER that has a shorter wait time. But these things, right, that are about what the workers are trying to do to make their shift easier, can have substantial impacts on a person's trajectory, depending, arrest versus the medical ER versus the specific psych facility. And so this makes me recall incidents I saw during my time with mental health outreach, where mental health workers, in this instance, called 911 and asked EMTs to take a homeless person who seemingly had both physical and mental health problems to the hospital. And the EMTs implied that the mental health workers were committing fraud and trying to get this person in when it really wasn't required. And so I can see this now as this sort of burden shuffling, but it was a failure of burden shuffling, and the mental health workers eventually gave up. And to quote Josh here, the stratagem here is pretty simple if you're a frontline worker. Navigate the protocols to shuffle the burden in a way that somehow makes your shift easier. So we could read this as people being callous or lazy, but it's also totally understandable. So these kinds of cases of the problem person are to some degree the bread and butter of the ambulance that's dealing with urban poverty. And it can feel really unfulfilling vocationally. And yeah, if you consider yourself a health professional, it might seem like a bullshit call. And since the patient is indigent, they may run into problems because the hospital won't want to take them because they won't get a reimbursement. And of course, this is totally relatable for many kinds of work. So as an academic and teacher, I'm happy to work, far beyond expected hours for a class where everyone seems engaged and the students have the opportunity to really put in the work. But if it just feels like a bunch of administrative stuff or, whatever, I might try to do everything I can to avoid it. It's super relatable, right? So you could imagine professors burden shuffling undergraduate students onto a graduate student TA, something to that effect. But what's amazing is that when this feels totally relatable, but when we start looking at things like policing or healthcare or other forms of street level work, academics often aren't thinking about these kinds of labor-shaped dynamics. So consider how what Josh is doing here might differ from some other approaches that are maybe a little more macro. So if we were talking about this in terms of what Foucauldians call governmentality or grand sweeping changes in how the state manages people through inculcating self-governance, or if we were just talking about this in terms of capitalist disciplining of the poor, we'd miss so much of what's actually shaping the things that happen to people. And so the long tradition of street-level bureaucracy has acknowledged that there's incredible discretion, but then just pushes to the next question is what's shaping this discretion? And what Josh's model here helps us see is that it's a labor process that's being shaped by both these horizontal and these kinds of vertical relations. And so to say something else about the vertical relations and how that relates to the horizontal ones, I'll tell another story about how things change when people know, when hospitals know they're getting reimbursed. So I once accompanied a mental health nurse to a client's family's house because they'd called to see if they could get an emergency hold. And the worker, this nurse, took his time getting there because he thought maybe if we showed up late, the guy would have run off already. So in a sense, he was trying to let time do the burden shuffling for him. But the man hadn't gone away, so the nurse did this thing. He called the hospital in advance, and he made a big deal out of the fact that the guy had Medicare, because Medicaid would not have covered the psychiatric hospitalization, but Medicare would. And once that was in place, he explained to me, it would be much easier to work with the police and with the ambulance workers, because the ambulance has already accepted that this hold is a legitimate one because they will get their money. So it sort of pulled all these things together. So once the vertical pressures of the bottom line are taken care of, then these horizontal relations are easier. So we have to consider all of this in Josh's framework, these questions of insurance and profit, and how this structures the way workers end up interacting with each other and this potential patient. So again, Bandage, Sort, and Hustle helped me continually ask how much of what I was seeing workers do in my mental health research was about, some broader governance project, but how much of it was just people trying to do their labor in a way that felt vocationally fulfilling while not being overly taxing and having to deal with things like appeasing your boss. And so this should feel very real because it's a thing a lot of us experience. And this is what we get from ethnography, good, in-depth, long-term ethnography, participant observation that you might not necessarily see from afar. So now I've just got some questions for Josh. And to some degree, he addresses this in the conclusion when he talks about policy and practice recommendations, but I want to give him an opportunity to expand on it here for the audience. So if we have these people who are being burden shuffled, such as the intoxicated mental patient who lacks housing, and these people are, as Josh says, quote, undesirable by all parties, what then is the solution? So who can and will address these vulnerable people in a way that's not just shifting them around? So is it another kind of emergency responder, or does it require a very different kind of intervention than that? And then the second question I'm wondering about is what role Josh sees for the police. So I was recently on a panel called Decarcerating Care that was about getting police out of mental health crisis response. And while everyone agreed that our systems over-rely on police, people on the panel often also noted that even the helping professions, such as social workers or ambulance workers, could play a coercive policing function that people experience as quite violent. So in the spirit of these ongoing discussions about defunding police, here's my question. Could sympathetic ambulance workers and social workers address many of the cases you describe without any police involvement? Or does your work make you think maybe some policing is necessary? The second part is, so perhaps do you think that ambulance workers are themselves part of the problem as well, in need of radical reform alongside this question of defunding or police abolition? And if that's the case, where do we go from there? So those are my two questions. Again, a real pleasure to be here discussing such an important book. Thank you.
Great, thank you so much, Neil. You really, those are total softball questions. So I'm sure Josh will have no trouble reimagining our society for us. So we're going to hold those questions and let our other two panelists speak before turning to Josh. And I've made some notes too, so we can make sure he doesn't dodge these tough questions. But thank you, Neil. Our next panelist is Dave Brady. Dave, the floor is yours.
I'm going to share the screen here, folks, and let me pull this up. Okay, and got some slides here. Okay, so it's a real pleasure to be here. It was a lot of fun, a good excuse to sit down and read Josh's book in its entirety. It's a really good book. Before I get into some specifics, I'll just say that this is really, Josh is really a sociologist, you know? This book has almost like I want to call it like a classical style, in that it's like a study of a classic institution, like the way we would study work or the way we'd study medicine or urban. And so it's in this very tradition that's great, and it's really neat. And beyond that, I would say the book is very teachable in lots of different classes. You could teach it in medicine, intro, work, stratification, urban, lots of different places. And finally, generically, I'd say that this is a book that we as sociologists could export to other disciplines and be quite proud of this export, and it would certainly gain the respect of the other fields. Now, let me be a little bit more concrete in my praise of the book. And there are many, many strengths. These are only a few that I wanted to highlight. Well, first, I mean, obviously the book gives us a really rich theoretical framework. It's definitely what I'll call the Berkeley School tradition of ethnography, where theory is on every page and it's in dialogue all the time. And I won't go into summarizing it. Neil did and others have as well. But this relational labor process approach, I annotate my notes. If you ever teach the book, you can use that. But it's really nice. It's really compelling. I think it generally works across the book. I find it very compelling and convincing. I think the various schemas, Josh is really, really good at coming up with little frameworks and schemas and ways to divide and sort ideas. So as these concepts of how, you know, ambulance works about spaces in bodies, like different parts of the body that need medical attention, as well as bodies and spaces and neighborhoods and homes and streets and so forth. And his book is divided up also in this really clever analytical way, where there's the within the ambulance part about the work of the ambulance, the bandage part. There's the relationship between the ambulance and other actors, like the police, like Neil said, the sort part, and then the ambulance underneath, which is the hustle part, which is about how the ambulance workers deal with this labor process of managers and bureaucratization. Also, the book just stands out as a really nice piece of ethnographic craft. And so methodologically, it's really well done. There's extensive time in the field. And you can't help but admire the commitment and the time that Josh put in. I also thought it was really cool that the book gives you an ethnographer's perspective from different perspectives. So Josh worked as a ride along with the supervisors, so he sort of saw the world from their side. He spent a lot of time shadowing the crews, where he was just kind of hanging out with the crews, but he wasn't actually in it. Then he spent time working as an EMT, and the book also gives you multiple perspectives. At times you're located within the hospital, times you're on the street, times you're in the ambulance bays, you're at the supervised place. So you really move around and you transport with these people. Now, also, I thought it was quite nice that Josh did this triangulation with the official ambulance records. It did some real nice quantitative research, just getting a sense of the basic patterns. Finally, it's really just a brilliant case. I mean, this is a book that really puts healthcare and medicine at the center of urban life and what Josh calls urban suffering. There's this story going around these days that the face of government for the poor is criminal justice. This is a discourse that's out there. And I actually think, I'm not totally convinced of this. I think the face of the poor of government might actually be healthcare. I mean, you know, you think about it, Medicare and Medicaid is $1 trillion. These are gigantic shares of people's lives. And so even more than criminal justice, I think healthcare and education may be how the poor see the government and how they interact with public provision. And last but not least, this book is certainly showing us what I'll call like the tip of the neoliberal sphere, and that it shows how healthcare is posted and transports across different places within urban settings. Now, if you know Josh, you know he's kind of a true, what I'll call Josh, I would say Josh is kind of like an intellectual arm wrestler. And he likes to have, you know, roll up his sleeves and get into debate with you. You can't be friends with Josh without having a vigorous debate over lunch or in a seminar and so forth. And so I have to write some comments that I'm trying to really provoke Josh and get him stirred up because it's more fun. So first I would say, as a suggestion or a question for the book, and really, I don't want to hear Josh's excuses. This is where he needs to spend the next 10 years of his career. And you got your work cut out for you, Josh. But first and foremost, one could make the argument from this book that racism is the central stratifier of urban settings today, especially in contemporary United States. And I'll make the case, and I think this wasn't necessarily the focus of the book, although it comes through, but this is really where the agenda should be going, one of the ways it could be going. So one of the things Josh does, he focuses a lot on the different kinds of cases. So the scheme of legit and bullshit calls, and that's sort of a central division in the book. But he says this is less crucial than the different kinds of people, and that's important. But in the process, so he talks about, like, you know, different people could be treated differently based on the kind of cases they are, not on the different kinds of people they are, or simultaneously. But this does not interrogate how we classify people into cases when many, I said most initially, and Josh said not most, but many calls are ambiguous and most of the people are Black, brown, and poor. And so a fair question would be to say, like, so when ambulance workers arrive on the scene and they faced an ambiguous case, and Josh and I don't know how often it is, but it's certainly not trivial that a lot of these cases are ambiguous. And if they face this ambiguous case, it is important whether it's legit or bullshit call, but I think there's a channeling that probably goes on. They may perceive the pain of Black, brown, and poor people very differently than white and upper class people, and that might shuffle people, if you will, into different classifications of kinds of cases. So I think the kinds of cases is endogenous to the kind of people, and I think that would be worth exploring. Now, we all know, and Josh shows us, that there's ample evidence in healthcare research that the pain of Black, brown, and poor people is trivialized. And we all know from social policy and poverty research that poor and Black and brown people are routinely perceived as undeserving of public assistance. And we see in Josh's book, this is a big theme, that the ambulance is pervasively partnering, interacting with police. So to Neil's question, I would say I kind of view healthcare as part of this police state in some ways. And I'm a little more pessimistic about the capacity of the ambulance workers to not exacerbate these racial distinctions. So what I would say that would be really interesting is for Josh to analyze his notes on this process of classification. So if you went through the notes and looked at every case where the kind of the client was ambiguous, and Josh has this great phrase on page 74 where he says he saw these cases as structural problems, whereas the workers saw them as moral problems. And I thought that was really, really compelling and a good example of how the workers are participating in the racial classification of the kinds of cases. So that would be my question. How do workers classify different kinds of people into different kinds of cases rather than viewing different kinds of people and different kinds of cases as competing factors? I would say the kinds of cases are endogenous to the kinds of people. And more to the point, when the workers are involved in classifying people as either bullshit or legit calls, this ends up worsening the suffering of these people and legitimating the public neglect of their suffering. So if we looked at these people that have what is perhaps a bullshit call, which just reflects the absence of social support and public policy to help poor people, what we end up doing is saying, oh, this is a bullshit call, and it ends up sanctioning these poor people, as opposed to saying the problem is the system's not taking care of these people. We don't have the social welfare system to take care of these people. And so a good example would be if somebody was inebriated and they're homeless, that would be viewed as a bullshit call, but this reflects just the breakdown of our whole social welfare system. And that ends up, I think, legitimating that public neglect. Okay, now beyond that, I would say a second big thing I would like Josh to encourage to explore is I think we could use more comparisons and what I'll call counterfactuals to fully develop the theory. So I think the theory is going to grow, and Josh has a long-term research agenda here. And as we all know, and implicit in the book, is that this political and institutional and structural theory that Josh offers is very determinative as a macro level process, but it only really shows up occasionally and a bit as a postscript. So it's on sort of the bookends of the book, and it's the framing, and Josh is very aware and conscious of this driving a lot of what we're seeing, but I wanted to see it sort of show up on the everyday a little bit more. So there's a trade-off here. By focusing on how suffering is we might neglect investigating why it's not prevented, which is a macro level political and institutional questions. By analyzing interactions with poor people, this can distract us from why there is so much poverty. And so that's where I really wanted to see a macro and political theory of what's going on here. And it does show up, and Josh is very conscious of that, but I wanted to see more. And so one of the things you could do is try to think about, are there settings where the ambulance has not been privatized in the way the setting has been done here? Josh told me offline that actually these days, no, all ambulances have been quite privatized. But it'd be interesting to think of a different way to organize healthcare that was more publicly provided that would change the whole narrative of this study. Also, I wanted him to instantiate how austerity shapes the care. So taking the themes in part 3, where the workers are basically always having to hustle and they're working on, there's very lean force, and what that does to the quality of care. So taking part 3 and applying it within part 1 and 2. But I also was wondering if ethnographers ever get into what I'll call like a counterfactual discussion with their respondents, where they would basically just talk to them and say, well, how would it be different if we didn't have homelessness? How would ambulance life be if we didn't have this epidemic of human suffering that we see in America's cities? Most other rich democracies don't organize their cities the way we do. The US is anomalous and really quite weird and strange. And it would be interesting to reflect and have healthcare workers think about, how would your life be different if you didn't have to face all these urban problems that are being neglected in so many other ways? So that's my question, is sort of how does this austere, privatized, neoliberal regime of public services shape the quality of care? And I would be curious to hear if Josh ever got into conversations with his respondents about this question, because I'm sure it's on their mind. Okay, thank you.
Thanks so much, Dave. Another really provocative set of comments. And I'm looking forward to Josh's responses in just a little bit. But we'll turn it over to our last panelist next, and that is Tania Jenkins. Tania?
Hi, thanks, Anne. First of all, I wanted to start out by thanking Josh and Anne for putting together this really exciting panel. I can certainly empathize with the difficulties of having a book come out in this pandemic. It is not easy. So we're doing what we can to really celebrate this really, really, I think, exciting book. So I'm really honored to be invited to be a panelist today. I wanted to start off by prefacing my remarks by sort of explaining a little bit from where I come from as I'm reading this book, as I'm sort of critiquing the book. And so I come at this as a medical sociologist who primarily studies medicine. I study the medical profession. I study medical education. And I'm also a hospital ethnographer. And so I have some experience with what happens after the rig leaves the trauma bay. But having spent, so much time in hospitals, I've actually never spent any time on an ambulance. And so it was really interesting to read Seim's really rich description, I think, of what life is like on the back of the rig. I think that was really, really useful for anybody who hasn't been on the back of an ambulance, which I expect would be most people at this point. So I also thought it would be useful to situate Josh's book a little bit in sort of broader medical sociological trends right now. I think at several points in the book, Josh mentions that this is a book that is trying to make sense of downstream workers, right? I think there's a quote on page 7 where Josh mentions that, it's a book that's trying to make sense of workers who are waist deep in the water, trying to pull people out of the river that are drowning. And that metaphor, that analogy, actually draws on a really popular metaphor within medical sociology. If memory serves, I think it's a metaphor that was popularized by Irving Zola, one of the founding scholars in medical sociology. And he described how a physician friend of his would talk about their work as a physician, right? As being a physician who's standing on the shore of a river and hears somebody screaming and jumps into the river and rescues that person, performs CPR, and does so just in time to see the next person jump into the river and then have to save that person. And that the physician is spending so much time rescuing people who need rescuing, to be sure, in this river, that they don't have a chance to actually look further upstream and ask, why are all these people drowning to begin with? And so, I think within medical sociology, there's been a push in the last 50 years to move upstream and to consider what's happening further upstream to really get at some of the fundamental causes of health and illness. But where Josh really sort of takes us to the metaphorical riverside to actually examine how patients get scooped out of the river. And I think that, for all that there's been an emphasis in medical sociology to look further upstream, and that emphasis is really important, it's kind of left the discipline hanging in terms of really understanding the microdynamics as they happen, as these folks are being rescued while they're drowning, metaphorically. So I think this contribution is a really important one to medical sociology. It really brings our gaze to the moment of rescue and also to the social forces that shape that rescue. I was really sort of fascinated by the analysis of really unlikely sources of medicalization. So Josh refers to, in the process of describing burden shuffling, refers to how police will often medicalize non-medical conditions, right? And you know, for the life of me, I've never heard of police acting as agents or as forces of medicalization. So again, I think this analysis actually sheds new light on social forces that are happening downstream that we ought to be paying attention to as medical sociologists. The book also fits in with parallel work that's happening in the sociology of health professions. There's another recent book that was just published earlier this year by Tania called More Than Medicine, where she examines the profession of nurse practitioners. And she found something rather similar to Seim in that a lot of social work is actually being performed by nurse practitioners. And I think an implicit argument in the book is that a lot of social work is happening by ambulance workers. And so I situate this book within a broader sort of literature that's grappling with the array of medical workers and the range of tasks and the kinds of work that they're doing. I think it leaves open a separate question of why social workers aren't doing more social work on the front lines, and that's perhaps a book for a different day. I think much like David and Neil, there's a lot to love about this book. I first of all was blown away by the prose. You know, I think it's a good academic book doesn't have to have amazing writing, but when it does, like this one, I think it's such a pleasure to read. I appreciated the interludes between the different parts of the book. I think that it helps sort of the reader wrap their heads around the different moving parts and sort of gave us a forest for the trees kind of sense of where the argument was going. It, as David pointed out, is hugely theoretically rich. There's a concept in the introduction of social gravity, and I'm not sure if this is Josh's invention or if it's something that he might have borrowed from somewhere else, but I think I've never heard that before, and I thought it was brilliant. This idea that hardship and social problems tend to congregate at the bottom of the social, the broader hierarchy. I really, really liked the perspective on labor, right? And I think already my colleagues have sort of proposed ways in which that sheds light on certain social processes. There are other ways that it eclipses other perspectives. And to be fair, Josh actually recognizes this in the book, that by focusing on labor, the focus is necessarily then taken away from the patient experience, for example. There were a couple times in the book when I found myself thinking, there was the example of Jose, I think that was mentioned in chapter 6. This is a homeless gentleman who was found unresponsive, eventually was found to be inebriated, and there was a discussion between the police and the ambulance workers and eventually the nurses of where Jose should go. And the question I had in the margin was, well, what is in Jose's best interest? And that didn't seem to sort of come through, but again, I think no book can do it all. And I think it's sort of a broader question that gets raised in the conclusion. I was also really, really thoroughly impressed by how well thought out the analysis was. I can't tell you how many times I had a question or a comment that I jotted down in the margins. One of them was, what about power and hierarchy between vertical relations of power and hierarchy between nurses and ambulance workers, for example. And then just a couple of pages later, a couple of paragraphs later, that was addressed by Josh. And so there were a lot of times when I actually found that a lot of the concerns or questions that I had were already addressed just a few moments later. I was also really taken aback by how candid and vulnerable Josh is in this book. He admits his own role and responsibility in certain things, like starting to view the term Hispanic panic, for example, as code for insignificant suffering. I was really, as an ethnographer, I was really sort of impressed with the degree to which you were really quite vulnerable and open with the reader. So So I leave you with a couple of questions that remained unanswered for me at the end of the book, although there were very few, like I said. Most of my questions were answered while reading. The first is I was hoping you could elaborate on the ethics of being both an insider and an outsider in this field as an ethnographer. How did you handle the shades of gray between data and non-data? So in other words, how much, or were there times when you chose not to use a conversation or an anecdote or an experience as data in the book? You know, to what extent were your colleagues talking to you as Josh, the fellow EMT, versus Josh, the researcher? So I was hoping you could elaborate a bit more on that. Another question I had was about where this designation of bullshit versus legitimate calls comes from, and how it gets reproduced between ambulance workers. You do a great job of operationalizing this distinction in chapter 2. You note, for example, that this is largely a logistical distinction in terms of which interventions are performed in legit versus bullshit calls. It's also a moral distinction. But I found myself wondering about the role that training plays in shaping some of these distinctions, and whether training could change in order to at least prepare EMTs and paramedics a little bit more for those 60% of cases that are considered to be bullshit. You note that most of the training is actually geared towards legit cases. And in the conclusion, you call for changes in paramedic and EMT training to teach ambulance workers about the more upstream conditions that shape health. But to what extent does EMT or paramedic training shape understandings of bullshit versus legit calls? And should it change? And if so, how should it change to better prepare ambulance workers for the reality of ambulance work? So I'm going to stop there. Thanks again for having me on this panel. It was a real pleasure to read, and I look forward to hearing Josh's response.
Thank you so much, Tania. You know, I think we've all been on a lot of Zoom events in the last 6 months, and I'm just totally blown away by the quality of these 3 panelists' comments. Thank you all for taking the time to engage with Josh's work so rigorously. So we're now going to turn the floor over to Josh. I think you're charged with reimagining the police, providing a political theory of why suffering occurs, and explaining ethical issues. So I'm sure you can do that very quickly. So we'll turn it over to Josh, and audience members can start thinking about questions you might have, and sort of towards the end, we'll start to pop those into the chat to engage with Josh directly. So Josh, I'll turn it over to you.
Hello, everyone. Can you all hear me? Yeah, good. Okay, well, first of all, thank you all for coming, and thank you to the panelists, and thank you to Anne for organizing this. I deeply appreciate it. I want to give you a little insight about, so as the panelists have said, this is a book about the role that the ambulance plays in the polarized city. It's primarily a piece of urban sociology, medical sociology, and the sociology of work. And in writing the book, I set out to accomplish 2 goals that I think should be stated. So the first goal was to understand how the ambulance contributes to a governance of urban suffering. And I argue that it does that in 3 ways. I argue, firstly, that the ambulance helps to bandage suffering bodies, offering simple and superficial solutions to the deep and complicated wounds of a capitalist and racist society. I argue that the ambulance helps to sort suffering bodies, helping to distribute them across an array of often fragmented and contradictory institutions. And then thirdly, I argue that the ambulance helps to hustle suffering bodies, rushing them through periods of intervention, not necessarily rushing them to intervention, but rushing them through periods of intervention, usually doing this in the name of organizational efficiency, or in some cases profit. So that's the first goal of the book, is to make sense of the mechanisms by which the ambulance helps to regulate or manage that population that suffering that tends to concentrate towards the bottom of the urban hierarchy. And then the second goal I have for the book is to introduce a labor-centric frame for understanding how that governance unfolds, and thinking about it as a labor process from a somewhat orthodox Marxian perspective of what the labor process is. So I jotted down some of the questions here, and I'll do my best to answer those while thinking about the overall goals of the book. So Neil, thank you very much for your comments. I'll just jump right into just directly answering them. So what do cases, what to do with the cases that are seen as so-called bullshit? Yeah, it's a good question. You know, and this is a question that has occupied the concerns of ambulance managers, administrators, and policymakers. Now, they don't necessarily use the language of bullshit, but they recognize this problem that workers on the ground also recognize. They just use a different vocabulary for it. And the problem is that the opportunities for intervention that ambulance crews have is often mismatched with the problems that they confront on the ground. So ambulance workers have a, you know, kind of casual and colloquial description of this as often being bullshit. And I should say that in my records that I examined, over 60% of the calls that Tania mentioned, over 60% of them involve little medical intervention beyond a transport to the hospital and the collection of vital signs. And they just don't really have the tools to do anything else besides so-called legitimate deep medical intervention beyond taking somebody to the hospital. And so this is not like a secret. I'm not revealing something that's unheard of, right? So managers and policymakers have already recognized this, but their solution to this is usually diversion programs, right? And they try to figure out ways of how do you get ambulance patients, or how do you get 911 callers to not inundate the ambulance so much? How do you divert them away? Or do you do something like education programs? You try to teach people on how you are really supposed to use 911. My intervention, or my suggested intervention, is not to transform, you know, the clientele or the patients, but to rather transform one of the very few institutions that people can turn to when they need aid. And so one of the things we can do is transform the vocation. I think this speaks a little bit to Tania's question about, you know, maybe we do some education for the crews rather than education for the patients, to make some sociology and train them about the upstream effects. But I don't pretend that that's going to solve all these problems, because you could teach them about the importance of housing first. You could teach them about the importance of you know, yeah, I mean, you could do housing first. You could teach them the importance of sobriety centers and things like that. But if those things actually don't exist, if there's no opportunities for them to make interventions and to use those tools, then it's not going to do much. So we are seeing some developments in, you know, structural competency training for paramedics and EMTs. But if it's not coupled with actual transformations in the tools and instruments that are at the disposal of crews, it's not going to actually make a ton of sense. So that's why I argue that we can't just transform the ambulance internally. We also have to adjust the safety net and the menu of opportunities that exist beyond the ambulance. And so as of right now, ambulance crews, in the case that I studied, and this is generally the case across the country, really only have one choice with patients, right? And that's to take them to an emergency medical center, right? To take them to an emergency department at a hospital. Some places have added in sobriety centers and things like that, but for the most part, that's the only option to them. So I think there has to be a transformation in the ambulance, but then also of the safety net more broadly. Neil asked a tougher question about police abolition. What does this book offer insight into that? And then more directly, Neil, you asked, could ambulance work be done without the police? My short answer to that is yes. So I want to reiterate that most of these calls, whether they have law enforcement present or not, most of them are for low acuity, so-called low acuity, non-emergencies, or what crews are calling bullshit. Work that doesn't really involve a deep critical medical intervention. About a fifth of calls overall in my data set involve interactions with law enforcement. And those interactions are more common on those so-called bullshit calls. And the majority of them are for behavioral, psychiatric, and, you know, substance abuse problems. I don't want to suggest that police officers have not done anything of consequence on these calls, but I'm not convinced that law enforcement was the institution that was needed for the interventions that they were making, right? So even the good things I saw them do, if they were, you know, well, even medical interventions. I've seen officers do CPR. I've seen them administer Narcan. But this all raises the question of, do we need cops to actually do these things? And I think the answer is generally no. Now, if there are any ambulance workers here, I don't really know for sure if anybody joined. But you know, I think the typical justification for ambulance or for police presence on ambulance scene is that they secure the scene and that they provide safety for ambulance crews in otherwise dangerous situations. And so Neil asked me this question, you know, a couple of weeks ago. I've been thinking about it. I can't think of a single incident in which the police actually made me feel safer in my work, as an EMT for 9 months, and I'm not really all that convinced that I saw that in my observations. And of course, police officers and ambulance crews, another common circumstance in which they interact that is often on these so-called legit cases is a traffic collision. But again, do we need law enforcement on those scenes, or could you have another public safety infrastructure that could handle the directing traffic away from a dangerous area? So the short answer here is no, I don't think that the police are necessary in the cases that I observed in my fieldwork. I don't at the same time think that my book is the end-all discussion of police abolition. I only offer a particular viewpoint into policing, right? It's from a particular viewpoint from the ambulance, but still, I think this text could lend some insights into those discussions. Now there is this issue, Neil, about should we just defund policing and redirect that funds into medical infrastructure, or redirect it into ambulances and emergency departments? I mean, it's probably better than not doing that, but you raise a good point about that these institutions can be punitive in and of themselves. And there is a carceral punitive logic within the ambulance that I, partook in and witnessed. So we could get rid of police officers and they wouldn't be handcuffing anybody anymore, but you'd still have the case where on ambulances, you have not handcuffs, but leather limb restraints and interventions that are highly coercive. So I do think that the larger discussion of police abolition would be wise to also think about discussions of how do you transform the carceral logics that are baked into a lot of safety net and social service institutions, beyond just saying, let's get the police out of hospitals, let's get the police out of schools, or let's get the police out of ambulances or off of ambulance scenes. You have to also think about the coercive and somewhat punitive orientations that these institutions and the actors within them can often take. Dave, very tough questions, but I'll do my best here. Yeah, so you asked if racism could be a central stratifier here, and I agree. I think racism, along with capitalism, is a central stratifier, in particular a central stratifier of suffering itself, right? So that is probably the main force of racial stratification. I think that that should be a primary concern in the book, is that suffering in the city concentrates towards the bottom of an economically and racially polarized city because of the forces of capitalism and because of the forces of institutional and structural racism. Now, that's not to say that you can't have racism within the ambulance as well. Of course, you certainly could. And I appreciate Tania bringing up the case of Hispanic panic, which is this terminology that I learned in my fieldwork that essentially associated inauthentic suffering with Latino women, particularly older women who have immigrated to the United States, although it was a category I learned that was really applied to anybody that crews would see as Hispanic, or could potentially apply to any of those people. And the idea was that, that Hispanic patients will exaggerate their suffering. And therefore, when you see them suffering, you don't necessarily need to take it quite as seriously, because it could potentially be a theater or an act, that they get carried away in their grief. And so that learning that terminology, hearing that terminology in my fieldwork taught me very early on that visions of authentic and inauthentic suffering are, of course, racialized. And we also see this in other language, like the language of the 911 abuser. I link that in the book to the racialized language of welfare queens, somebody who's abusing the system. And same with this, visions of like a suspicious and deviant patient. I link that in the book to classifications of like Willie Horton and associating Blackness with criminality. So all that certainly exists in the book, and it's certainly a key part of how ambulance crews understand the different kinds of people that they interact with. But I'm trying to emphasize another set of biases that are also at play within my field setting that is not very obviously detailed in the existing literature, and that is not the difference between kinds of people, which are real and exist, but the difference between kinds of cases, meaning the types of problems that ambulance crews see, or the types of problems that medical crews see, and mainly seeing these as workable or variable workable problems. Now, the question of, does race influence how people get categorized into these kinds of cases? I think the answer is yes, and I will admit it's a fair question to ask of me, and it's something I probably should have spent more time in the book addressing. But yes, all things equal, or imagining a world in which all things equal, I do think it's the case that a Black patient is more likely to have their problem seen as a bullshit problem than a white patient. But I want to be really clear here that the bullshit problems and the legit problems, all of them are overwhelmingly Black and brown, right? So that is important to keep in mind. It's not as if you have all legit problems are white patients and all bullshit problems are patients of color. That's just not true. They tend to be patients of color across the board, across these intervention severities. But I'm not saying that, of course, racial classification certainly plays a part there. Yeah, and this sometimes I get heat for this claim, but I still say it because and part of me didn't believe it when I was in the field, but over time I just kind of realized that it was, from my point of view, true. And it's this claim I make in the book that ambulance crews would rather work a legit patient, a legit problem that is attached to a Black body, than they would a bullshit problem that is attached to a white body. And I just think that's true. And I have evidence for that in my research in terms of, it's not been uncommon for me to be, with an ambulance crew and they're responding to, sometimes they'll call it like a little, they'll call it like a life alert button problem. It's not always the company life alert, but so, like you have the button that you push that sends the emergency response. A lot of those things get accidentally activated, or people, they push them too preemptively. And so those are often seen as usually as kind of bullshit problems. And they tend to concentrate in like the hills and the wealthier parts of the county where there tend to be whiter populations. And, I've been on cases like that where they would wish that they were on a gunshot call, or they wish they were on a violence call. And of course, gunshots and violence are not limited to Black and brown patients, but the language that crews would use when they would say, oh, I wish I was on a gunshot call, or I wish I was on a violence call, that was racialized language in my view, that they would see those as primarily being cases in Black and brown neighborhoods. So yes, there certainly is racism in the case of Hispanic panic, the language of 911 abusers, all that stuff. And that certainly shapes how problems are perceived to be either legitimate or bullshit. But this distinction between legit and bullshit has some kind of relative independence, meaning that we should understand it, yes, in interaction with kinds of people, but it also has its own kind of independence. Another quick example is that people can slide on this continuum between bullshit and legit. And this is really obvious with like frequent flyers. So frequent flyers usually seen as calling for bullshit reasons, but you have a few frequent flyers where these people are chronically ill, and they will, on some calls, be considered legit because their symptoms and the problems that they present with seem as more legit from a biomedical standpoint. And so those are cases in which somebody's race and their gender and other things are relatively controlled for, and they slide on this continuum. And you asked about the worker's sanction of bullshit calls, is it worsen suffering and legitimate suffering? I guess I could see that argument being made, and I would be, sympathetic to that argument, but I'm more concerned with the legitimation that happens with the other language that is not really used by ambulance crews, but is really used by journalists, sometimes even academics, and used by public policy officials and things like that, which is not, they're not using the language of legit and bullshit, but they use the language of emergency and non-emergency, or they'll use the language of appropriate and inappropriate care. And they don't use the language of frequent flyers, but they call frequent users super utilizers. So I'm more concerned with that language, because that's the language that's really in the public discourse, and that's the language that's really doing a lot to delegitimate the needs that people have on the ground. I think ambulance workers, in using this cold language of bullshit, are really just reflecting that broader structural problem that the instruments on the ground are mismatched with the problems that ambulance crews face. So that'd be my primary concern. And then the issue of comparison and counterfactuals. Yeah, should I have spent more time thinking about the etiology of suffering and why suffering concentrates towards the bottom of the city? Maybe. I mean, part of me feels like, can't I rely on the existing literature that really does a lot to already demonstrate that this exists, right? And so to Tania's point about the stream, I try to make this point in the introduction where it's like, I'm confident that in my field work that racism capitalism and larger structural forces are concentrating suffering down into these areas that ambulance crews tend to interact with. And my mission in the book is not to follow the stream upward as a sociologist, but to make sense of the workers who are at the end of that stream trying to pull people out. And these are workers that, as Tania mentioned, play an important role and that are often ignored in the literature. And this kind of touches on what Neil was talking about, is ignored in this larger literature on governmentality, but also on disciplining the poor. So yeah, maybe I should have, but I wonder if there would have been a trade-off if I would have spent more effort in the book writing about those things and making sense of them theoretically. It would have redirected my attention away from the workers, and I think the contribution here is to focus on the workers. You raised an interesting point about the future. What would be some future counterfactuals or future directions for this research? One option, I think it's a good option, is to examine public ambulance operations. And just to clarify, it's not that public ambulance operations are not common or not popular. They are. I just think they operate under a somewhat similar logic as private ambulances. So they tend to run on a fee-for-service model. They tend to, still purchase wage labor rather than like salaried employees. So there's a lot of consistencies in their operations. But if I was to examine a public ambulance operation, I think that could help me fine-tune my first objective of the book, which is to understand how the ambulance contributes to this governance of suffering through bandaging, sorting, and hustling. But if I wanted to pursue that second objective of the book, which is to advance this labor-centric model for understanding the governance of suffering more generally, I feel like my time might be better spent in actually leaving the ambulance and going into other settings: probation offices, welfare offices, mental health services, emergency departments. I think there's other settings that could take that approach. And so as of right now, I'm kind of leaning towards the second option and advancing the second objective of the book. And then how does neoliberalism shape care? So I think that this is the discussion I want to have about in the third part of the book on hustling of bodies and these neoliberal pressures that exist. Certainly, I think they're intensified within private operations, but they exist often also in public operations, where the name of the game for an ambulance service, whether you're public or private, is you're usually getting most of your revenue through billable transports. And when you're dependent and your revenue is dependent on billable transports, this usually translates into an intensification of the exploitation of workers. They're trying to get workers to grind through as many transports as they possibly can. And I think we're also seeing this in public services as well as private, although perhaps not as intense. So yes, and all of that is to say, when you're hustling through cases so quickly, I think this produces a couple of problems for care, right? One is it exhausts ambulance crews. It risks their bodily health and could potentially make them poor care providers. It also exhausts them emotionally and can intensify some of the cold interactions I detail in the book. And then Tania, I'll be quick. Yeah, ethnography, this trade-off between being a researcher and being a worker. I had some benefit here that I was a ride-along for a year before I did the actual work. So by the time I did the work, everybody knew I was a researcher. And if it happened to be the case, so most of the paramedics I worked with, they had known me from the year prior. I was doing ride-alongs either with them or with crews around them. And if if a paramedic was my partner for the day and somehow didn't know about me in the company, or they're a new paramedic, I always made it really clear to them that I was a researcher, and I told them I took notes and things like that. And I always told them that if they didn't want me to take notes on something, that they were welcome to do so, that I was never going to identify them. There was one case in which something happened, and it wasn't illegal, but it very obviously violated company policy, and it involved multiple people, and a few of those people came up to me directly and asked me not to record that in my field notes and not to mention it in any of my writing, and I've honored that, and I didn't even write it in my field notes. But yeah, there is this tension between being a researcher and a worker. When I was an EMT, though, I focused on being the best EMT that I could be. That was my primary concern. I didn't take like a ton of field notes in the field, especially compared to when I was a ride-along. When I was a ride-along, I took a ton of field notes in real time. When I was an ambulance worker, I couldn't do that because I was lifting up bodies and steering an ambulance. And I think this actually raises an important question about the trade-offs between doing what we could call participant observation, or what we might call observant participation, right? The trade-offs between doing, observations from the sidelines versus doing inactive, or sometimes it's called embodied ethnography. And when I did that shift from a ride-along to an EMT, a number of my friends in grad school and a number of people even in the ambulance and even a number of professors had this kind of attitude, at least from my perception, that, oh, I was going to do some real ethnography now. I was going to get really deep into the weeds here. And there was some truth to that, because I did gain some special insights by doing the actual work, but it also severed a lot of my opportunities in the field when I became an EMT. So when I was a ride-along, I had incredible vertical access. I was able to ride along with ambulance crews, but then also spend time with supervisors. I also went to a number of upper management meetings. Once I became a worker, it was obvious I was cut off from that. They said explicitly, you're not doing any more ride-alongs with supervisors. So there was a trade-off that I think is worthwhile, and just doing, the so-called hardcore ethnography where you're doing the actual work, the deep participation. I think we're too quick in sociology, in my opinion, to just consider that to be automatically good. Some ethnographers almost speak as if that's a moral superiority that they have, that they did the actual work, whereas other ethnographers did not. So I'm not convinced by those arguments. And then the origins of the legit and bullshit distinctions, does it come in training? So in training, nobody ever says legit or bullshit, right? It comes from a training on the streets, right? So it comes from your initial work on the streets and you hear this language that gets picked up. I'm not the first ambulance ethnographer. There's been ethnographers in the ambulance since the 60s. And you can find different iterations of this terminology, of people being frustrated that somebody's calling the ambulance for what, from their point of view, seems like an inappropriate problem. So a problem that's mismatched with the ambulance. And the language has changed. It wasn't always legit and bullshit. Sometimes they talk about good runs and bad runs. And so there's that has kind of always existed. And I think it's just a reflection of this structural problem. And I suspect that the language of legit and bullshit will change in the future. There will be new terminology. So making interventions into education, I don't think really is the answer, unless it is coupled with transformations in the actual tools and instruments that workers are given to address these problems. Should ambulance workers do this upstream work? I think you raise a really good point. I think my knee-jerk answer has always been yes, that they should. And my response to that is I'm not super happy with like ambulance diversion programs. I feel like a lot of that leads to abandonment, right? So people will get diverted, and the idea is that they would get diverted and then inevitably just disappear from the ambulance. And so I think that you have an institution of EMS across many cities that has, a number of problems, but still exists as a critical piece of public infrastructure that already exists. And I feel like if we could throw some social workers in there, but not just throwing social workers in there, but also expanding the opportunities of interventions that they can make, I feel like that could do a lot to address these so-called BS problems. Because I don't want to have anybody read this book and come to the conclusion that I want people to not call the ambulance for their BS problems. I want the ambulance to be readjusted and reorganized along with the safety net more generally to respond better to these problems. And with that, I think I'll end it. Thank you all very much.
Great, thank you so much, Josh. We will now turn to audience Q&A. I've invited you to start typing your questions into the chat. I see a few coming now, so we'll start to go through those. And just get to as many as we can. As we get closer to 1:30, I might kind of bunch them together. So I see a question from Dan in the chat about sort of long-term coping mechanisms for ambulance workers. So Dan, I'm gonna go ahead and unmute you, and you're welcome to address Josh directly.
Yeah, thanks, Josh. I love the book and the Q&A. It's been really fascinating way to spend my Friday night. I'm researching career sustainability of emergency physicians in the UK, and a lot of what you wrote resonated really. I was just wondering how you think ambulance workers in your study work long term, and if the language of bullshit and legit cases is a survival mechanism.
Yeah, so a survival mechanism in terms of to help them detach, to not see their own, I guess, yeah, I could see it as a survival mechanism because it doesn't have them recognizing that the problem is within their institution, let alone within the work that they're doing, it ends up redirecting the problem downward towards the patient and saying that they are the problem because they are calling for some so-called bullshit reason. Dan, can you speak a little bit more about your question regarding long-term sustainability? You're talking about like the tenure of the workers and how long they're working and things like that?
Yeah, like you did the job for 9 months, and reading between the lines, it clearly took a bit of a toll. And I was just wondering, people do this for 10, 20 years and probably get a lot better at it, and become more valuable to the healthcare economy. And I just wondered how you think they managed to do this. It doesn't seem to make sense to work as an EMT or a paramedic for 20 years. It seems very, very hard way to earn a living.
Yeah, you're right. There's a ton of turnover. I mean, it makes sense because the job is really not that good, particularly in private ambulance services. So I got hired, pennies above the county's living wage. My union ended up getting a $2 increase for me later on, for me and the new hires a little bit later on, but still that wasn't a ton of money. And then paramedics, who are the higher trained to these parties, and I should say the paramedics are the ones that are doing most of the clinical intervention. They go to school longer. They're doing all the, deep clinical interventions into the body. EMTs are doing most of the driving and the lifting. That's a pretty cold description, but that is generally true. So it's not a very desirable job in terms of its material rewards. A lot of people see it as a stepping stone, and I feel like that's one of the reasons why I was able to do the kind of research I did. So when I approached management after I'd done my ride-alongs, I said I wanted to be a worker there. And that it was actually management's idea, I should say, as a middle manager said, you should work here. And the reason why they said that is because they needed workers, right? And so then I told them, well, I'll work here, but I only want to work for like a year at most. They were like, yeah, that's fine because we need more workers. And they also recognized the turnover. So in the first, there were in my hiring academy, where it was all the first cohort of workers that were with me. Management came down and had a pizza day, and they brought us pizza, and the manager sat down and said, look, we understand that you all want to get other jobs. And they just said, just be honest with us. And if you need to leave, you need to leave. And so it was, the first week of my employment, there was this acknowledgement that there was going to be high turnover. A lot of, I don't want to gender this too much, but a lot of the younger men that work in the private ambulance, a lot of them have aspirations to get jobs as public firefighters. And public firefighters in the state of California, as far as I know, they all have to be EMT certified. And fire departments in the country, especially big urban fire departments, 90% of their work is now medical work because they're responding to these types of calls. And firefighting does seem in many ways to be like a working class masculine dream job because it's like you're doing heavy lifting, you can get some big muscles, and you also get paid incredibly well, especially relative to private EMS. So there was a lot, but there were also some people who got hired and they wanted to be going to nursing later on, or they wanted to go to medical school later on. So there's a lot of people who had aspirations to leave. Then there were also people who wanted to stay there for a long period of time, and there were also people who got stuck there. So there's not many of these firefighting jobs in big urban fire departments. So I worked with a lot of guys who, they constantly wanted to get, they constantly applying for the local fire department jobs, and they just, for whatever reason, weren't getting them. I don't know if they weren't scoring high enough in exams or whatnot. And there was this really interesting dynamic. I didn't touch on the book because it didn't really add to the analysis, but I've always wanted to write it as an article, as this awkward interview that happens, like a spontaneous interview that happens on 911 scenes, where you have one of these paramedics that wants to get hired into the fire department, and they'll share a call with the fire department, so they'll try to show off their skills. They'll basically try to hand them off their resume and tell them they're applying for the job, especially if there's a fire captain on scene. So there's a lot of really interesting dynamics there between fire departments and ambulance crews, which I didn't touch on in the book all that much because it didn't really advance the analysis at hand. But yeah, so short answer is there's quite a bit of range on folks and how long their tenure is at the company, and it makes sense that a lot of people rotate out of the company and out of the profession somewhat quickly, and management knows this.
Great, thank you. And the next question I see in chat is from Arvind about the increased volume and sort of concerns around legal liability. So Arvind, please go ahead.
Sure. Thank you. Thanks, Josh, and thanks, Anne, for organizing this event. I'm a big fan of the ASR articles, so I'm like looking forward to reading the book. So my question is, I actually did an ethnography of 911 emergency centers, so even upstream. So they also use like similar language. I resonate a lot, the bullshit language that they use a lot. So my question is on, does the general trend and the increase of calls, like, we get a lot more 911 calls, plus now people have a venue to complain. They go to social media to complain if the cop or the EMT did not arrive, their neighbor is playing loud music. So does that, two of them put together, the legal liability associated with response time, render certain types of calls as bullshit calls, while others are categorized as appropriate calls, especially the frontline workers, the EMTs or the cops? Do they sort of actively try to avoid those liability issues, or does that not even play into the conversation? Thank you.
Yeah, great question. So liability, and particularly like issues of contractual compliance, play, occupy a significant amount of the mental attention of managers more than workers. So the way that this company works, and this is somewhat similar with other private ambulance firms in the state of California, is they have a location monopoly. They have a contract with a local government to provide ambulance services within that particular location. And the main concern, like the main measurement of quality service, which I think is really problematic for a number of ways, but the main measurement for quality service is response time, right? So so companies are usually, obsessed with making sure they make good response time within these contracts. And so that's the main issue of liability. And, it's measured automatically on a computer, right? So as soon as you get the dispatch, the clock starts, and then you need to get on scene to that given time. Ambulance crews generally, I didn't see any cases in which they would deviate from, like, they would never try to disobey, or try to show up late to an ambulance scene. I think that has more to do with their sense of vocation. They weren't trying to avoid ambulance calls, because as a call is dispatched to them, even if it's issued as a low priority or even if it's issued as a high priority, people just don't trust dispatch for the most part in the ambulance. I think that they're at best just good guesses, right? So it could be the case that somebody's dispatched for a low priority call, but once you get there, that person could be really sick and be seen as a legit case. So they always just tried to get there for the most part as soon as possible. And so issues of liability and contractual compliance, that really concerned managers more than anything else. And so managers were really concerned with making sure that there were enough ambulance workers on the street so that they didn't get fined. So that's the deal, is if they break the contract, if they violate, they have too many calls that are late, they'll get fined. And this company at one point was getting fined like $400,000 a month. And so that was really concerning for them. And so what they need to do to really prevent those types of fines is to just add more. I mean, the answer is kind of obvious, right? You add more ambulances on the street because you expand coverage. But you don't want to add too many ambulances on the street if you're a manager, right? Because that just increases the cost of labor power. And if you have a ton of ambulances on the streets and then they're not responding to ambulance calls very often because there's too much coverage, then you're losing money. So this is where this concept of the lean fleet really comes into the book, where managers are really trying to dial in a lean fleet, a fleet that is not so fat. They use this language of thin, fat, and lean. They want an ambulance fleet that is not so fat that while it would avoid late calls and would avoid fines, it would increase the cost of labor power. And at the same time, they don't want an ambulance fleet that is too thin, because if it's too thin, that would reduce labor costs, but at the same time would increase the likelihood that they're going to get fined. So I would say that would be the primary concern of liability and particular issues of contractual compliance. Certainly there's in speaking to what Neil was talking about how ambulance workers or frontline workers are always trying to navigate protocols. People will often cite protocols and cite things about certain laws to often win in some type of a debate or something with another frontline worker. So you'll see ambulance crews, if they're getting any heat from emergency department nurses about about them bringing an undesirable patient, then they'll sometimes cite EMTALA, or they'll cite some hospital law that could get them in trouble. But yeah, I would say for the most part that it didn't really orient much of their conduct. And for the most part, I would say ambulance workers were pretty obedient to changes in rules and regulations, because every year protocols change. not in a dramatic way, but they'll change in terms of the types of medications you give and how much dosage of a medication you give on a certain call. And I was always actually pretty surprised that when the clock turned and it would be a new year, and paramedics did a lot to learn these new protocols and learn these things because they're really concerned about getting sued. And they're particularly concerned about getting sued far into the future, right? It was always this nightmare of paramedics, or what they would frame as a nightmare of them being called into court. Not necessarily that they're getting sued, but they're called as a witness on some case. And so they're really concerned about their ability to recall this information, and they always want to make sure they do it pretty well. So especially in their documentation, they're really careful about documenting things, so it seems like they're operating within the confines of the law. And I would say for the most part they are, and I was pretty surprised by that.
Thank you.
Yeah.
Great. Let's see. I see a comment from my pal, Jeremy Levine. Jeremy, I don't know if you want to actually take up airtime, you're welcome to, or if any of our panelists have any follow-ups, or if people have any more questions. Tania, did you have a follow-up? Go ahead.
I did. A question I didn't have a chance to get to, but was curious about, Josh. You do a great job in the book of talking about the jockeying over bodies, burden shuffling between different occupations. I wondered if there was jockeying over stuff. And it kind of speaks to, you point in the beginning of the book to our kind of collective imagination about what happens in ambulance rigs. And, I'm sort of thinking here about, how many medical dramas I watch and the fact that it's probably way too many, but that I often see there's this kind of jockeying over ambulance workers trying to get, to resupply their rig from the hospital supply, room. I also wondered if there were similar instances of maybe police coming onto the rig and taking supplies that they might need for themselves. And so what about the things? Were there sort of debates or fights over stuff?
Yeah, that's a great question. I would say for the most part, people were pretty generous with sharing things. So there's an important vertical struggle we haven't really talked about between ambulance workers and managers here. And so even though ambulance workers are mostly obedient to things, they tend to have a fuck management attitude on a lot of things. Management is almost universally despised amongst workers. And so there was some ideas about how could you kind of subtly screw management. And one thing that popped in is just gifting out blankets. So ambulances actually carry a fair amount of blankets to cover patients with and things like that. And so a number of crews, when I first started there, were just giving out all of these blankets to homeless people on the streets. And they were even giving out some of their jackets. So they were giving out some of like their EMT and paramedic jackets. And this was driving management nuts. And so they tried, I can't remember. So then they started keeping track of the blanket distribution. But I would say on the front lines, I had this whole chapter dedicated to burden shuffling and the tensions between the ambulance workers and the police and the nurses. But I try to make clear in the book that while that tension is there and while it's really interesting, for the most part, there's not struggle between these groups. I would say for the most part, there's actually solidarity between them, right? A shared solidarity of they don't like their managers that much either, right? And the shared solidarity that the clientele tends to annoy them all. And so there was this sharing of resources. So nurses at hospitals frequently gave us the codes to their break room against the wishes of their managers, in which we could go in there and raid their sodas and things like that. And police officers, especially if it was hot, we would frequently give them ice packs from the ambulance and they would shove it in their bulletproof vests and things like that. And they might want gloves because they're often doing, interacting with patients and stuff. So they would frequently ask us for gloves, and for the most part, we gave it to them. I don't think police officers gave us anything though. It was kind of a one-way relationship. But the idea is that if you're nice and you're generous with some of these workers, that they might cut you some slack on a debate you might have about something else later on. So it was this idea of kind of producing a lot of goodwill, and sharing objects was often a way to do that, particularly because those aren't your objects as a worker, right? That's the company's objects or the hospital's objects. So we were okay with gifting those things away. And there was never really a scarcity in those things. It wasn't like the police officers were taking too many ice packs or taking too many gloves, or that we were taking too many sodas. So it wasn't a scarcity problem that sometimes I read about in the news and other ambulance services across the country where they have a scarcity of the resources, and so they're stealing these things from the hospital. And that just didn't appear in my field site.
Let's see. Thank you, Josh. I think both Dave and Neil have a follow-up. Maybe we'll go like the last power 5 minutes. If Dave and Neil, if you both want to like quickly throw your question out, and Josh can get to what he wants to get to in the last 5 minutes. Dave, do you want to jump in first?
Yeah, sure. And it's nice to go alongside Neil because I like the back and forth with Josh about whether law enforcement was ever the helpful institution. And I like Josh's testimony to the fact that it was mostly inappropriate. It wasn't really that improving. But I wanted to push Josh and say, maybe we could make the same argument for ambulances. Like, wouldn't it be better if most of the time these were social workers there instead of ambulances? It's certainly not a super efficient use of extremely expensive healthcare workers and technology to deal with inebriated homeless people. That's not a great use of anybody's time. So my challenge would be to say, some of what we see here is like the rent-seeking behavior in occupations that are closing instead of work for themselves, because it creates an essential role for them. And to your point, Josh, just to say, the LA Times did a beautiful analysis of most of LAPD's calls, and the evidence was overwhelmingly consistent with your view. Most of the time, we don't need police there, and we'd be better off and more efficiently dealing with it with social workers. So my question is just, wouldn't we be better off with fewer ambulances and more social workers?
Yeah, I would agree. We would be better off. There's a difference though, because most people, I don't know for sure for policing, but most people who are in contact with the ambulance are volunteering for those ambulances. For the most part, they are calling. And so I get really concerned with efforts to try to divert callers away from one of the few institutions that's promised to them. But yeah, you're right. And I try to emphasize this in the book, that it would just be a better situation if you had these upstream structural interventions in building a stronger safety net and a better welfare state, where you wouldn't have people at the bottom, at the end of the stream, needing to call the ambulance so much. And I think those interventions could matter not just for the bullshit calls, right, but also for the legit calls. I don't know why, I think, you emphasize it or I emphasize it like 60% of these ambulance calls are for these so-called bullshit reasons, but I don't want to suggest that ambulance crews are only responding to, they're also responding to severe medical emergencies, gun violence.
To your point, Josh, a lot of it, if we had better preventative healthcare through a public social welfare system, they would become less necessary, right? That would be in the legit calls as well. Yes, and so the idea is not, and even if for some reason we cut out all of these bullshit calls, that's the fantasy for managers, right? And that's the fantasy for a lot of people, is like, just even the workers, that's a fantasy, right? Get all these bullshit calls out of there. Even if that happened, it would still be the case that the ambulance would be contributing to this governance of urban suffering and towards the bottom of the urban hierarchy. They still would be doing that. They would just be responding somewhat exclusively to these legit crises. What the legit crises, in addition to what ambulance crews are seeing as non-emergent problems, they all concentrate towards the bottom of the urban hierarchy. And so if we had, significant, robust safety net interventions that could prevent all this wounding that happens towards the bottom of the urban hierarchy, wounding meaning, not only your gunshot wounds and the probability that you're going to get into a car accident, but also, the insecurity of being chronically unhoused and things like that. So yeah, I think, ultimately you're right, but I certainly don't want to turn this into ambulance abolition. So ambulance transformation in combination with transformations of the welfare state more generally. And I think that's rooted in serious analysis, not just in my soft spot for ambulance crews, which I obviously have.
Great. And Neil, yeah, you want to jump in with the last word, and we'll let Josh say whatever he wants.
Yeah. So I just want to speak again to the question David brought up about counterfactuals and comparison. So one version is, you do a parallel study in Sweden or something. But I think, you could also, I don't know if this even exists, right? But like Cadillac service, specialized ambulances for rich people. And so this, for me, is like the kind of comparisons to some degree that I was doing with elite private mental health care and public safety net care. And there's a sort of parallel, which is that public safety net mental health care, half the time, these are housing agencies. They're about getting people off the street. They're about keeping people out of jail. And then the question, the counterfactual there is like, oh, if we had more resources, could we actually do real therapeutic work? And what you see with rich places is, yes, that's true. But there's also different kinds of bullshit calls that show up. which is like families saying, you know, my kid stopped doing their homework. Can you monitor that for me? Right. And so you end up with these, or, you know, or some other thing that people are like, this is not what I do. Like, I'm a therapist, but you're all suddenly tasked with these other kinds of things. So I'd be curious, like, yeah, if you had a fancy ambulance for rich people, would it just be like the bullshit calls of like the old white lady who accidentally pressed her button?
Yeah. So I think that, you know, to be clear, there were calls in I don't really emphasize them that much in the book because they're just certainly not as frequent relative to the grand scheme of ambulance calls, but there are calls, you know, rich people, white people, wealthy people towards the tops of all these social hierarchies that we're mentioning, you know, they get sick too, they run into emergencies, they also call 911 ambulances. And I surprisingly didn't find that much of a difference in the kind of a legit bullshit ratio in at the neighborhood level, at least. So when I had all my medical records, this is in the appendix of the book more than anything, but I had all my medical records, geocoded them to the tract level, and then kind of compared which ones are the most severe injuries. You know, I classified records on severe and not so severe, and then calculated a ratio of kind of like severe to non-severe injuries in emergencies. And it actually wasn't patterned in a significant way by neighborhood. The real difference was just volume, right? It's just the volume of the legit calls, the volume of the bullshit calls, they all concentrate towards the bottom. So my observations just kind of naturally just always pulled me towards the bottoms of these urban hierarchies. So it was hard for me to make some of these comparisons because in the grand scheme of things, they were kind of few and far between, but yeah, people are relying on 911. So there are some private services. So particularly for the non-urgent type stuff, there are, you know, your insurance, if you have a nice insurance package, it might cover some regular hospital appointment meetings by way of another ambulance service that exists outside of the 911 system. I don't know much about those services. I do imagine that they are probably, you know, more likely to be funded by like private insurance than they are by public insurance, but I don't know that actually for sure. But you're right, that would be an interesting comparison because it is the case that I'm talking about the governance of urban suffering, which I just mean how suffering is patterned and distributed throughout the city. And I'm not trying to suggest that people towards the top don't suffer or that they don't need medical interventions. I'm just saying the type of case that I looked at, I tended to gravitate towards where that suffering tended to gravitate, and overwhelmingly it gravitates towards the bottom of that hierarchy. But yeah, certainly those comparisons would be interesting.
Well, I think our time to wrap up has come. Thank you so much to all of our panelists, and congratulations to Josh on the publication of this great book. Thanks.
Thank you all for coming. I really appreciate it. Take care.
Great. Have a good one.